Good evening, everyone. My name is Michelle Galazewski. I'm a Partner Relations Director with Eversight. And on behalf of everyone at Eversight, I would like to thank you for joining tonight's program, DMEK Complications, Management, and Patient Selection. In an effort to eliminate all background noise, all participants will be muted throughout the duration of the webinar. If you would like to ask a question, you may do so by typing your question into the Q&A panel at the bottom of your screen. We will address all questions at the end of the webinar. At this time, I would like to introduce our speaker for this evening. Dr. Lorenzo Cervantes is a board-certified ophthalmologist and a fellowship-trained specialist in cornea, external disease, cataract, and refractive surgery. Dr. Cervantes received his medical degree cum laude from the Downstate Medical Center College of Medicine and at the State University of New York, where he was elected a member of the Alpha Omega Alpha Medical Honor Society. He completed his residency in ophthalmology at the North Shore LIJ Health System in New York, where he also served as the chief resident. He completed a fellowship in cornea, external disease, and refractive surgery at the Eye and Ear Institute of the University of Pittsburgh Medical Center. His clinical practice interests include the medical and surgical management of corneal diseases, small incision and complex cataract surgery, repair of intraocular lenses, and refractive surgery, including LASIK. He is experienced in the most advanced corneal transplant procedures, including DMEK, DSEK, DALK, and the use of the Boston keratoprosthesis. Dr. Cervantes is an experienced and accomplished surgeon, having performed several thousand intraocular procedures, and was the first surgeon to perform DMEK for the treatment of corneal edema in Connecticut in March of 2015. Dr. Cervantes is a diplomat of the American Board of Ophthalmology and a member of the American Academy of Ophthalmology, the American Society of Cataract and Refractive Surgeons, the Connecticut Society of Eye Physicians, the New England Ophthalmological Society, the International Society of Refractive Surgery, the Cornea Society, the Patent Society, and the Eye Bank Association of America. He currently serves on the board of directors for Eversight and regularly teaches other surgeons advanced techniques in corneal transplantation and cataract surgery. On the subject of cornea, he has authored several textbook chapters and peer-reviewed journal articles and has lectured both at national and international meetings. In October of 2017, Dr. Cervantes joined Dr. Joseph Sokol at Connecticut Eye Specialists in Shelton, Connecticut, to help provide some of the most up-to-date cornea and cataract care in the region. When not practicing medicine, Dr. Cervantes enjoys golfing, running, snowboarding, and watching football games with his family. Dr. Cervantes, you can, I don't know when you find time to sleep, but you can go ahead and begin.
Thanks for that great introduction. Hi, everybody. My name is Lorenzo. It's a beautiful night here in the Northeast in Connecticut. I hope it is where you are as well. Thanks for joining us tonight. We're going to be talking about transitioning to DMEK, patient selection and complication management. Always a favorite topic of mine. It's been a pleasure working with Eversight for the past 5 or 6 years, as Michelle just described. We're happy to that you are joining us on this mission as well. My time is volunteered, so I don't have any relevant financial conflicts to disclose. For those of you, who haven't made the move to DMEK, tonight I hope to convince you that learning and offering it is worthwhile. Then we'll go over some pearls that will make the transition a successful one. And everyone's favorite subject, we'll go over some of the complications unique to DMEK so that your learning curve might be faster than mine. We'll do this all by briefly going over the history of endothelial keratoplasty, going over the evidence-based benefits of DMEK, addressing the transition concerns some surgeons might have, as well as the fundamentals that we should keep in mind when we're performing DMEK. Then we'll spend the majority of the time going over complications and their management. We'll also, now this talk is a variation of the talk that I give for Eversight's virtual wet lab, which I'll plug at the very end. Now first, let me introduce you to Garrett Mellis. This is the godfather of DMEK and endothelial keratoplasty. If you ever meet him or see him, please be sure to shake his hand. Now, endothelial keratoplasty is one of the greatest leaps forward in the history of cornea surgery. All within the last 20 years, um, it's proven infinitely superior to penetrating keratoplasty in the treatment of endothelial dysfunction, in terms of quality of vision, speed of recovery, and complications. Its superiority is reflected, by the adoption of cornea surgeons, and in 2012, DSEK overtook penetrating keratoplasty as the most commonly performed cornea transplant in the United States, with that gap ever widening. Now, endothelial dysfunction is the most common indication for keratoplasty in the United States. And within endothelial keratoplasty, we also see an interesting trend up here in the top right, where the use of DMEK is increasing. This green line is increasing at a much faster rate than DSEK is declining. This might be explained by the growing numbers of recent cornea fellows who are now joining the ranks, offering DMEK as their endothelial keratoplasty of choice. For those of us who have not offered DMEK to our patients yet, it's often cited that iatrogenic donor tissue damage, a steep learning curve, and increased rebubble rates have been barriers to transitioning to DMEK. I'd like to offer some reassurance that that the symbiotic relationship that we cornea surgeons have with our eye banks have alleviated many of these concerns. So why should we start offering DMEK? Or why was it even why is it so important for us? Really, it's for the benefit of our patients, right? Everything we do is for the benefit of our patients. Compared to even DSEK, DMEK has been shown to get better visual acuities, faster visual recovery, and even lower rejection rates. And because of even better chances of getting to 20/20, and because of lower higher order aberrations, patients with premium IOLs might still be able to achieve their goals, like this patient who got multifocal IOLs despite having a history of advancing Fuchs dystrophy. And this is this video shows a patient who has gotten DMEK. Their corneas are very clear, and they're doing very well. The eye banks really have been a godsend in terms of tissue preparation and shortening the length of OR time. Two major concerns that surgeons had in the acceptance of DMEK. The eye banks are essentially doing the first part of the surgery, which involves the tissue harvesting and the tissue preparation. The staff are highly trained and will have prepared more DMEK tissue than any of us cornea surgeons will ever do, decreasing tissue waste, primary graft failure, and OR time. Aside from peeling the endothelial graft, the eye bank technicians also provide orientation markings to your preference and preload the graft in either of two glass injectors. That's the Dork tube, which I prefer and use, and the Jones Strico tube. This allows the surgeons to perform DMEK efficiently, prepare the eye, inject the graft, unfold it, stick it with a bubble, get in, get out, very repeatable, very efficient procedure. Let's go over some things to keep in mind that will help, with your DMEK success. DMEK, as many of us are learning and teaching it, is essentially a no-touch technique. because the graft comes to us already preloaded, we never really even have to touch the graft. And all the tapping and manipulation that we do is through the cornea, which create fluid waves that push and pull the edges of the graft. As we watch this video, you might see that I'm actually teaching one of my colleagues how to do DMEK, and you'll see deliberate taps that I'm describing to my colleague, almost calling the shots, and how I'm going to manipulate the graft while we're unfolding it. Everything is very deliberate here, and each tap almost seems to have a purpose in mind. We also know that endothelial cell count is not affected by how long it takes to unfold the graft. So patience is really key. If we're struggling to unfold the graft, really just take a breath, sit back, relax, take our time. It's very common for us to struggle a little bit, feel like an hour has passed, but yet maybe only 5 minutes have passed. A great study was shown, by Chris Salas that there's really no significant endothelial cell loss in grafts that took 5 minutes versus an hour to unfold. Also, older grafts unfold easier. So if you're getting started, ask for tissue that's older than 60 years old. They unfold almost really readily, even within the injector. And in case you're worried about age doesn't affect endothelial cell loss in transplants. The eye bank also places an orientation marker on the graft, like an S or a 1 and 2 mark, so that you can clearly know which way is up. And probably the most important thing to never, ever forget is to always make an adequately sized inferior peripheral iridotomy to prevent pupillary block. And you can do that either preoperatively or intraoperatively. Believe it or not, the easiest cases to perform DMEK are phakic patients. Their anterior chambers shallow very easily, making unfolding, a breeze. One might make the case that this is actually where you should start, performing DMEK. The bulk of the crystalline lens pushes the iris forward, allowing the anterior chamber to shallow. It really is quite easy, but they're few and far between. So most people will start performing DMEK in pseudophakic Fuchs patients with normal axial lengths, and that's a great place to start. Once you're feeling confident performing DMEK in these patients, and if you're confident, with your cataract surgeries, you might start combining, triple procedures, cataracts with DMEK. But just be wary there that you're performing these types of surgeries. In normal axial length eyes, they can become a little bit challenging, in longer axial length myopes. Now, I routinely see my patients at 1 day, 1 week, and 1 month. And each visit has their purpose. At 1 day, the most important things to me are the pressure and the bubble size. I certainly want to make sure that they're not in pupillary block and that their air fluid level has cleared the PI. At 1 week, the most important thing to me is that the graft is attached. Fortunately, in my practice, we have an anterior segment OCT that we can check for graft attachment. But if you don't have an anterior segment OCT, it's okay. Very frequently, you can kind of tell, even just by asking the patient how their experience has been over the last few days, whether or not the graft is trending towards detachment. If the patient says that they started to see once the bubble was gone, And every day is a little bit better and a little bit better and a little bit better. If you look at the graft and there's a little bit of a detachment, you can be reasonably assured that they are doing well and you don't have to worry about them so much. But if they come back at a week, they say that they had started to see better when the bubble was gone, and they start to say that, you know what, I'm starting to get a little bit foggier and foggier. It might be that that graft is trending towards a larger detachment, even though they might not look as detached at the slit lamp, and they might be a reasonable candidate for rebubble, at the at that time. At 1 month, I'm removing the suture at that time, and also starting the taper of steroids. Very often patients come at their 1 month with a large improvement in their vision. All right, so what cases do I not offer DMEK? Well, maybe an eye like this. I wouldn't recommend this eye being your first DMEK case. The view is terrible. There's a large irregular pupil, a large iridectomy, an anterior chamber IOL. We could very easily lose the graft posteriorly here, or traumatize the graft against the lens. And it probably won't hold a bubble in the anterior chamber very well. So this eye, this kind of eye would be a great case for a DSEK, and in a situation like this, there really is no significant visual advantage for DMEK versus DSEK, at least in my own experience. Other types of cases where DMEK might be challenging are in patients who have had prior vitrectomy or high axial length myopes, and those types of eyes, it can be very difficult to shallow or flatten the anterior chamber to facilitate graft unfolding. All right, so in summary of what we just talked about, the eye banks make it really easy for us to adopt DMEK at this point. Some of our prior concerns of graft damage, long OR time, that has been essentially taken out of our hands and done very well by our eye banks. DMEK does not completely eliminate DSEK from our repertoire, and there still is a place for DSEK, like in complicated anterior segments. And in case you didn't know, now's a great time to accept DMEK. It's ready, and I think everyone can learn this procedure. All right, I'll move on to complications, and here we're going to talk about. Well, when I discuss complications, I tend to describe it in terms of when they occur. In terms of DMEK, complications can occur when we're preparing the graft, intraoperatively during DMEK, and postoperatively as well. So when we're preparing the graft, this video is when I was preparing my own tissue, and if you watch carefully, this is where I'm tearing the peripheral rim of Decimase away from the graft, and I slowed this down so you can catch what happens here. I think I'm peeling the peripheral rim, but oh no, I've torn the graft completely in half. In a situation like this, I actually had some text training in the OR and a few reps in the OR, and I just listened to a talk about performing hemi DMEK. So I had some time to catch my breath, take a seat back, explain what I was about to do, which essentially was just use half of the transplant. I took the half that had the S on it, so I didn't have to worry about orientation markings or which way was up. Surprisingly, I found that the graft was able to unfold, just as easily as a full a full graft. As I'm explaining what hemi DMEK was, nobody was any worse for wiser, in the OR, and everybody took it to be something that I intentionally did. Just after this, we'll see that the graft rebubbled beautifully, centered, and this was actually one of my first 10 DMEK cases, and 5-6 years later, she's still completely clear. So despite something as traumatic as tearing a graft in half, you can still make the best of something like that, as long as you well, I had a little bit of background information there, but I was still able to salvage it. Okay. Before we inject the graft, actually here on the at the top here, I'm starting to. This is one of my first experiences with the Doric injector. I was still getting a feel for it, and I had inadvertently ejected a preloaded graft. Fortunately, I was doing this over a jar of, or a lid filled with BSS. And that's one of the important things to keep in mind, that if there was to be an accident, make sure it happens over somewhere safe, and that this graft is always wet and findable. Fortunately, I had figured out how to disassemble and reassemble the injector, and I encourage all of you get comfortable with doing something like this in case something like this ever happens. But preloaded doesn't always mean perfect. Even though it was loaded perfectly, it was in my own hands that I sort of inadvertently ejected this graft. On the bottom right here, prior to preloaded tissue, and I was preparing this graft. Here I'm lifting up the graft, and on that rim I stain it with Vision Blue. I go back to the patient to remove viscoelastic while it's staining to save some time. And when I came back to that graft, I realized that my scrub tech had knocked over my punch, and I came back to a puddle of Vision Blue on the drape. Somewhere in there is the graft, but it was wet. It was in a puddle, and in diluting it, we were able to find it. So in knowing how to load the injector, we essentially folded this drape to create a more manageable pool, and from this little puddle, we were able to draw the graft into the injector and proceed normally, like a normal case. And again, this patient did well, because we got lucky and this graft never dried out, and it remained viable. All right, intraoperative, some intraoperative complications. We always have to make a peripheral iridotomy, and for many of my cases, I perform peripheral iridotomies intraoperatively because it was just more convenient for the patient to not have to come back to the office to perform a YAG iridotomy. But then occasionally we'll run into something like this. There is a large iris vessel. There is a large iris vessel at 6 o'clock that if you're not aware of it or can see it and avoid it, you can create a big hemorrhage like this. And a hemorrhage like this can be extremely inconvenient because the anterior chamber can fill up with blood. The iridotomy can clog, even though you've made a decent sized one. And fibrin will form in the anterior chamber, and that fibrin can act as glue that can prevent your graft from unfolding and prevent you and cause your graft to stick in the angle. Extremely inconvenient. So the way to manage something like this is, one, prevent it. Don't perform intraoperative iridotomies. But if you do encounter bleeding like this, put viscoelastic in the anterior chamber, right above the iridotomy and the source of the bleeding. And what that will do is to tamponade the bleeding and stop the bleeding from coming forward. I would rather have the blood collect behind the iris here. Fill the eye, not to, the NLP vision, but high enough pressure that it'll tamponade the bleeding, stop the bleeding if possible. Then leave, finish what you can do away from the eye, which is like putting your injector together. And by the time you come back, the blood will have coagulated, stopped. You can do your IA at that point. Just verify that your iridotomy is patent, and then proceed and inject your graft, as you normally would. The bleeding time might be a little bit longer for patients who are on anticoagulation, but that would be another reason, to try to avoid this in the first place and do peripheral iridotomies preoperatively using a YAG. All right. This is insertion and ejection is when we inject the graft. This is how it should be done. The anterior chamber has a low pressure. We are always engaging the injector, to the wound, and even though the graft is inside the eye, I'm not letting up on the engagement. Once the graft is in the eye, I have to depressurize the anterior chamber. I'm using my non-dominant hand to open up the paracentesis to depressurize, make sure that the graft is well away from the main incision. And then I'm going to guard the main incision with my second instrument to prevent the graft from coming forward. Down below, in this video, what I've done is I'm engaged, I'm inserting the graft, I'm talking to somebody right now, and I'm not paying attention to how pressurized the anterior chamber actually is. So as the graft goes in, my movements are touching the paracentesis, but I'm not letting any fluid out. I'm not paying attention to how deep the chamber still is, and the pressure is still high. So when I move to disengage, the graft starts to come out and I'm stuck. The graft is wedged in between my injector and the wall of the cornea. And I made a mistake there by trying to inject BSS to push the graft back in, but all that's doing is pressurizing the anterior chamber. I realized what I have to do is right there, I just sort of took a leap of faith, depressurized the anterior chamber, made sure that the anterior chamber pressure was 0, and then disengaged. The graft will always follow the path of least resistance. What you saw me do there at the very end was really the only thing one could do, is just very gently kind of tuck it back in, it doesn't have to be a traumatic experience for the graft. But this is something that care really has to be taken. This is one of the areas where excess manipulation of the graft will cause graft failure. All right, difficulty dancing. It's not really a complication, but just more, where frustration can get to you. Some things to keep in mind are that if you want the graft to unfold, you have to flatten the chamber. The iris has to push the graft up against the cornea and stop it from re-scrolling. Similarly, that if you want the scroll to move, let's say it's tucked into the angle, you have to deepen the angle, deepen the anterior chamber, allow it to scroll to some degree, and then push it or tap it, centrally. If you have an open graft that's decentered, sometimes tapping the limbus, way out, will accomplish two things. It'll temporarily, transiently deepen the chamber while pushing the graft, and that'll get an unfolded graft to move. And if you happen to see, like in the top there, that instead of, if you use the S stamp, if you instead of an S, you see a 2, then you can use fluid to kind of puff it or blow it open. And likewise, there are some configurations that are more challenging than others to unfold. If you're ever stuck, it's a great idea to use a puff of fluid to reshuffle, reorganize the graft into something that might be, more manageable. And if you want some ideas on this, go to patientready.org. There, Dr. Voldman has this great strategies on tissue unfolding that have been extremely helpful for countless surgeons. Gas or air misdirection or bubble misdirection. This can be a frustrating problem too. After finally unfolding the graft, after getting it centered, and you place your bubble under the graft, what might happen if the eye isn't pressurized the right way is that bubble can sneak behind the iris, and that'll cause the iris to come forward and close the angle. This is not a desirable configuration. And the most frustrating part about this is that if air does get behind the iris, the only way to get it out of there is to get it all out. Get it out of the anterior chamber, break the block that the lens might have on the iris, like here, and it'll eventually come forward. But you really, you might really just have to start over again. So the way to prevent this is to, once you get your graft flattened, use a small air bubble, a really small controlled air bubble to lift the graft against the cornea. That way it'll stay unfolded and it won't move. And then pressurize the eye with BSS, so that way the posterior chamber is full. If the posterior chamber is soft, air will want to go back there. Again, it'll just go wherever there's least resistance. So if the posterior chamber is full of BSS, there's not going to be any volume for air. The air will stay in the anterior chamber. All right, with partial graft detachments, let's say, they come back at a week. There's a clinically significant detachment. Bubbles, rebubbling is has been something that a lot of surgeons find unappealing. It's sort of like a I've failed. It's a mark of failure. But we know that 10% of grafts need rebubbling, and that's not an insignificant amount. So we really have to accept the fact that some of these grafts do need rebubbling. And will need rebubbling, and it's just a fact of DMEK life. I perform, I rebubble my patients at the slit lamp. As long as it's a partial detachment, and the detachment is lamellar, and I know that if I can get the tip of my needle behind the graft, then I'm not going to dislodge it. I have had the unfortunate experience where in rebubbling these patients supine, as these bubbles enter the AC, as you'll see in the video down there, as the bubbles rise, it can actually drag a large inferior detachment and drag it up and completely dislodge the graft. So in large inferior detachments, I actually prefer to rebubble these patients lying down supine. But for most of my my grafts, I'll do this at the slit lamp sitting up. You can do this however you want. I just happen to prefer it this way. In rebubbling these patients, I'll inject air into the anterior chamber. The pressure in the eye is going to go up. Then I'll move the tip of my needle back into the fluid level inferiorly, and then draw out BSS, or rather draw out aqueous. In drawing out the aqueous, the bubble is going to expand because the pressure inside the eye is going to reduce. And you can have pretty much a 90% air fill with good apposition with one needle stick, even in the sitting position. All right, complete graft detachments. Fortunately, this doesn't happen all that often. But if you do find this, this is not something that's amenable to rebubbling in the office because it might be completely scrolled. There's no way to guarantee that it's going to be centered, but these have to go back to the operating room. Once you're in the operating room, one of the challenges here and considerations is this something that you can actually reattach or recenter. But often, unless the S stamp is clearly still there, it can be very difficult to determine which way is up. You can try to restain the graft in the anterior chamber using Vision Blue. But in the couple of times this has happened to me, I've just replaced the graft altogether. It's less stressful. There's less of question in my mind of did I put it the right way? Is this going to continue working? And that's what I would probably recommend you do as well. All right, pupillary block is probably the worst complication that one can run into, and one that is totally preventable. Well, mostly preventable. There are, I say almost totally preventable because as long as you make a good size PI, I mean, a really good size. We're not talking one, for a narrow angle glaucoma where you can get away with like a small, iridotomy. But even if you're making one with a YAG, you really want this to be quite significantly large. Because if you do leave a patient with a large air bubble, like a 95 or 100% air bubble at the end of your DMEK, it's possible that the PI might still be occluded, and they might get a block from that. So make your iridotomies large enough that that fluid can confidently traverse that. I make PIs preoperatively with my YAG, and at the end of the case, I also dilate my patients to make sure that even the pupil gets big enough to clear the fluid level at a certain point. To manage something like this, it's important that you manage this swiftly. My patients have instructions to call me, overnight should they start to experience symptoms of, building pressure, building headaches, especially around the eye and the brow. And if I won't hesitate to go in and see them in the middle of the night, just to make sure that they are not in block. And if they are in block, take for example this patient who was in block. Their cornea was very hazy, cloudy, as you'd expect. And within a few minutes of burping that in, one of the paracenteses to break the block and lower the pressure, these corneas will clear, within a day or so, because the pressure is then normal. All right, so this is really something to look out for. I can't stress this enough. If the pressure is too high for too long, patients will have permanent vision loss. I include endophthalmitis here, because even though we can get endophthalmitis from any intraocular surgery, there is evidence that shows that performing fungal donor rim cultures have about a 10% positive predictive value for fungal endophthalmitis. So, even if you get a preloaded tissue, it comes with a section of the donor sclera that is meant to be sent for culture. I don't send for bacterial culture. I do send for fungal cultures for this reason. And in case you do get a positive fungal culture, follow these patients closely. That is a pretty high positive predictive value, for an elective surgery. And should there be any infiltrates that arise, especially in the interface, or any sort of inflammation that doesn't have a good reason, consider starting antifungal treatment at the earliest signs. You certainly don't want this to get out of control. All right, so invariably, complications will occur. It's just part of being a surgeon. But now that you have at least a few of these complications, shown to you, and in discussing cases with other DMEK surgeons with a lot of experience, hopefully you'll be able to recognize and then manage these complications before they become a serious problem. And believe me, DMEK is a lot more forgiving than you realize. All right, just keep that in mind. That said, if you haven't already done so and would like to participate in one of these great virtual wet labs that Eversight offers, with the pandemic, we did want to have, before the pandemic, we did and had active DMEK surgical education live and in person, through wet labs. But with the the inability to travel and meet in person, one of the things that we had actually developed was a way to use Zoom and smartphone technology to virtually educate and virtually learn, live. This has been really well received. And if you're interested in something like this, reach out to Michelle. We've actually published our initial experience with this in cornea, and that should be coming out in the next month or two. We'll go over, basically how to use the injectors, how to use how to unfold and unscroll DMEK grafts in an artificial surgical practice system, and again, that's been pretty well received. There's a there was a video there of yes. So this video is the view of one of our participants that we're we were coaching, basically in this time lapse where we're going over where to make incisions and how to hold the injector, and where's the ideal place to place the graft within the tube. And even though we're not in the same room together, it's like I can see what this surgeon is actually doing, and in coaching them and in doing this more than several times, we gotta get the hang of where what works, what doesn't work, and sort of overcome like what we would be able to achieve easily in person. But this surgeon actually did great. You'll see that she was able to unfold this graft and manipulate it on her first try. So hopefully if you choose to do something like this, that'll be your experience too. We actually have a wet lab coming up next weekend, with a star-studded cast of proctors, and yeah, I hope to see you there. And I hope you enjoyed this webinar. Good luck with your with your transition, and good luck to your patients as well. Yeah, thanks for spending it here.
Dr. Cervantes, we do have a couple of questions. If anyone else would like to, just enter your questions into the Q&A panel at the bottom of your screen, and we will address them now. So first question is from Dr. Jalaj. Do you inject the graft with Life Force C, or do you inject out all the Life Force C and fill the dork tube with BSS? Do you think it matters?
Oh, great question. I, by the end of the injection, you might find that the anterior chamber, is full of Life Force C or the previously Optizol. But by the time you sort of dilute and sort of unfold the graft with, that eventually gets diluted out. Now, I will tell you what I do in practice. In practice, what I actually do is very carefully under in a lid of BSS, I will draw BSS into the injector, carefully so that the graft stays in the wide portion of the injector. And so it just sort of floats there, and I'll fill and dilute the Life Force C within the injector so that there's less that I have to dilute once it's inside the eye. It's a very simple and straightforward, slow drawing up, movement. I think that's something that, that I find useful and easy to do so that I don't have to worry about it afterwards.
Okay, next question is from Dr. Crane. To rebubble at the slit lamp, do you go through your paracentesis or use a needle to make a new incision?
Oh, good. Another good question. I use a needle, and I do not go through a paracentesis. I find that, after prepping the eye, after anesthetizing the eye, I'm doing everything that I can to, keep the sterile field and not introduce, any possible microorganisms in a semi-sterile field, at the slit lamp. So my 30 gauge needle is going through conjunctiva, going through just, when I say conjunctiva, I mean, I'm really going through like as close to the limbus as possible, but passing through conjunctiva, going through, the limbus, going through cornea. So all of that is going to close, once my needle has been withdrawn. So I am avoiding the paracentesis, in that respect, and I'm trying to avoid opening the paracentesis as well.
Okay, we have a comment and question from Dr. Dhaliwal. Great presentation, Dr. Cervantes.
Thanks, Steve.
And he would like to know, have you ever used TPA for fibrin in the AC?
Oh, no, I have not. I have not used fibrin in the AC.
Okay, next question is from Dr. Ali. Pertaining to preloaded DMEK graft, is there any issue of directly injecting Optizol from the tube into the AC?
I've thought about that for a long time, but there's I don't think there's any issue. The endothelium is already bathing. If you think about it, the endothelium is already bathing in the Optizol or the Life Force C. So we know that it's endothelial safe. But again, if you spend the time to, dilute it out, there's, I guess another angle of answering that question is, will the Optizol or Life Force C diminish the adherence of the graft to the stroma? But I've not found that to be the case or a concern of mine, especially if you do end up diluting it out, and after performing a large air bubble, kind of massaging the cornea, you will get rid of a lot of a lot of the fluid in the interface, with a full air bubble fill.
Okay. Question from Dr. Jung Lee. Once the graft is centered, do you inject air for complete air fill for a specific period of time, then reduce to 95%?
Yeah, I think you're going to find that many different DMEK surgeons have their own preferences. Because I, when I did my fellowship and I started out in practice, all I was doing was DMEK. Oh, sorry, all I was doing was DSEK. So a lot of my bubble management habits stemmed from that. So my DSEK bubble management habits were to keep the pressure in the anterior chamber high for like 5 to 8 minutes, and then reduce the during that time I would use like a Lindstrom roller to massage, and push down on the cornea to squeeze out fluid from the interface, and then reduce the pressure to physiologic pressure for another 2 to 5 minutes while that adheres. I sort of do the same thing during DMEK, where I will keep the pressure in the anterior chamber high for 2 to 5 minutes. Use that time to again use a Lindstrom roller to push fluid and massage fluid out from the interface for whatever it's worth, and then bring it back to physiologic pressure, essentially with like a 90 to 90-95% air bubble fill at the very end. So that's essentially my bubble management. Some people will fill the anterior chamber up completely and just leave it at physiologic pressure and then discharge them from the OR, at that time. I've done that a few times and without any problems, but you sort of have to do what you feel comfortable doing.
Okay, we have a question from Dr. Ahmed Omar. Excellent presentation as usual. Would like to know how quickly in most cases you expect the visual improvement to happen, and how long does it usually take to achieve the desired corneal clarity, completely no edema?
Oh, this is a question that patients love to ask. The what's really amazing about DMEK is that you might start to see corneal clearing as soon as week 1, where patients come back week 1, and if the rest of their optical system is great, they might come back 20/20. It's incredible. But if there are other problems, or if those cells just need some time to perk up, you'll start to see clearing within the first few weeks. But yet there's still, I tell patients this, there's still clearing and healing that might take 3 to 6 months, to stabilize, or even longer, depending on the level of corneal edema. But once you start doing DMEK, you'll find that the clearing is really faster, than DSEK.
Okay, we have another question from Dr. Huang. When the graft was ejected out of AC, do you use it again or give up?
Oh, well, I would probably say don't ever give up on a graft, because you don't really know how much damage is done. In that video that I've showed you, I really thought that I had mangled that graft and squeezed and rubbed it with my glass injector on the outside of it, but that graft ended up clearing. Again, it's surprising like how resilient these grafts are to what we perceive as severe iatrogenic excessive manipulation. Many of us also don't have eye banks with readily available tissue in the room next door. I know some surgeons are fortunate to have something like that, and I'm not one of those surgeons. So if it's clean, if it's intact, if you can load it into the injector again safely, I'd say go for it and see what happens. You know, what's the worst that would happen? You know, if you're not injecting that graft, you're bringing that patient back to the operating room, you know, to put a new one in there. You know, if you put this graft in there and it fails, well, it's failed. But you know, at least you'll be mentally prepared, you know, to to order another graft and you know, have that discussion with the patient later.
Okay, and we have another question from Dr. Ali. I have experienced that part of the DMEK graft stuck within the sulcus is difficult to unscroll indeed. What will be the best advice dealing with this situation? And how about if bound to happen, part of the graft trapped within the wound?
When part of the graft is stuck in the sulcus, meaning behind the iris, I just wanted to clarify that, you know, behind the iris. Yeah, the reason why something like that might happen, where the graft gets behind the iris, is that the pupil is not constricted enough. You can avoid a situation like that by using myocol just before injection of the graft, you know, to bring that pupil down as tight as possible and have the effect of the myocol as strong as possible just before, you know, injecting the graft. This is also another reason why you know, combining cataract surgery with DMEK can be challenging, because you need to dilate the pupil to take the cataract out, and then you have to use myocol, you know, to bring the pupil back down. But if that pupil doesn't come back down, you know, significantly, that's one of the problems that you'd have to worry about, especially in somebody who has a floppy iris. But once if the graft is trapped in the you know, in the pupil or partially stuck under the iris, there's no physical way to push that graft out with fluid. You physically have to grab it, you know, and if you have intraocular forceps, that's, you know, one one way of you know, getting it out of there. You know, take your intraocular forceps, find a small bite, you know, to hold on to it, a small but secure bite, and just pull it back into the anterior chamber. You know, you're going to lose a few cells in that spot, but if you do it once and you do it well, you know, you don't risk losing the entire graft. If it's trapped in the wound, you know, half in, half out, you know, sort of situation like I showed you in that video, the best way to deal with that situation is decompress the anterior chamber. So that way it's not forced all the way out. Decompress the anterior chamber. And again, you know, just as atraumatically as possible, use a blunt instrument to kind of just push it, you know, back into the eye. And then once it's inside the eye, suture it shut. You know, I always suture my incisions shut with one single, you know, 10-0 nylon as soon as the graft is inside the eye and it's safe and away from the wound.
Okay, and we have another question from Dr. Jung Lee. Have you seen a graft decenter or fold on itself right after air injection? If so, how did you manage it?
If it's decentered or folded, the only way to manage that is to get rid of the bubble and kind of start over. The bubble, you know, if the graft is attached to the cornea and a bubble is underneath it, there's surface tension there. You're not going to be able to move the graft under a bubble. So you have to kind of start over. You know, use a cannula, draw the bubble out. You know, in drawing the bubble out, the chamber is going to, you know, flatten, which should help keep the graft open. You know, once it's once there's no more bubble, unfold it like you would have. But you really have to get rid of the bubble and kind of you know, recenter it under fluid again.
Okay, it looks like we don't have any other questions at this time. I just wanted to make one more mention about the virtual wet lab that's taking place on Saturday, May 22nd. Tonight is the last evening that registration will be open. So if you are interested, you can go to our website and register. The registration currently is only open to US-based attendees due to timing, but if you are interested at an international level, please feel free to reach out to someone and we can certainly work something out for you in the near future. I would like to thank everyone again for joining us this evening. The webinar has been recorded and it will be available on our website to view on demand soon. A special thank you to Dr. Cervantes for serving as today's speaker and for providing us with your invaluable expertise on this subject. I hope everyone has a wonderful evening. Thank you.